My topic today will be on diagnosing motor neuron disease and its challenges. I will start with a case vignette. So this is a 65 years old man presented with weakness of the left hand, started 9 months ago. It was progressively worsening and he's now unable to hold small objects. 4 months ago, the left foot, there's left foot weakness started 4 months ago, and he's now having a foot drop. And there are a few episodes of trips and falls. And this is associated with muscle cramps, but there's no weakness, there's no numbness. Recently, the family members also noticed that he has got slurring of speech. So on examination, there is breast Georgia, reduced palatal elevation, tongue atrophy, fasciculation, nasal speech. There's a wasting of the small hand muscles, the left more than the right, and there's a left foot drop, high stepping gait. He was unable to walk on heels. Fasciculation was noted over both biceps, thighs, and calves. Hoffman was positive on the right side, and there's right-sided clonus and bilateral upgoing plantars. As you can see, the strength, muscle strength testing wise, there is some asymmetry, especially the upper limb. There is some, the elbow extensor is particularly weak, and also the finger flexor and extensor is also weak. And for the lower limb, especially the ankle dorsiflexion is only power 2. So I think that can explain the left foot drop. And deep tendon reflexes, there are hyperreflexia and hyporeflexia, especially there is some asymmetry, especially on the right side, there's hyperreflexia over the biceps and knee and ankle jerks. So this is muscle wasting, tongue wasting and atrophy, and also small muscle of the hand wasting. So amyotrophic lateral sclerosis of ALS was described by Dr. Jean-Marie Charcot. He is widely regarded as the father of neurologists. He's a French neurologist. He actually described the clinical pathological correlation of ALS. And in his description, he described it as the large cells of the anterior horn appear too few and atrophic, and the neuroglial is sclerotic. Motor inertia caused in the lower limbs by the suppression of cerebral action may be complete, absolute. Muscles, however, in such cases do not lack nutrition or only in the long run because of protracted inaction. The anterior horn provides the nutrition for the muscles. Nutrition actually is a term Charcot used repeatedly in the study of the lesion of the anterior horn. So what it means is that the muscles appear to be atrophic, but the problem is not in the muscles. The problem is not in the nerve. Actually, the problem is in the anterior horn cell in the spinal cord. Motor neuron disease, I will use the term motor neuron disease and ALS, amyotrophic lateral sclerosis, somewhat interchangeably. Okay, so ALS has an incidence of about 2 to 3 over 100,000 population. It is actually not a common disease, but actually it is not rare. 90% of the cases are sporadic and 10% of them are familial. There are few genetic mutation has been identified, particularly SOD1 mutation described in 1% of ALS. Recent years, there is a discovery of this C9orf72 repeat expansion, where there is a syndrome of ALS and frontotemporal dementia and psychosis. The median age group of onset is in someone in their fifth to sixth decade. There is a slight male preponderance, and there are classes of cases in population of Guam. Just in case you don't know where Guam is, it's actually a small island in the Pacific. And it was linked to consumption of neurotoxin or familial susceptibility. There's also a subset of group of US war veterans, and somewhat higher incidence is actually noted among athletes. So this picture is Lou Gehrig, where the eponymous syndrome comes from, because ALS also known as Lou Gehrig disease. And on this picture here is Alayaha Mokhtar Dahari. He was a Malaysian ex-football player, Malaysian football legend. He also suffered from ALS. However, there is actually no direct causation reproduced. A brief history of motor neuron disease. First is described by Dr. Charles Bell, who was a British neurologist. Then clinical pathological correlation by Jean-Marie Charcot in 1869. After that, Lou Gehrig passed away in 1941, and later on, Evans-Corio diagnostic criteria was introduced in 1998. And 1995, the first FDA-approved Riluzole And then ALS functional rating score in 1999, and then subsequently 2007, FDA approved another drug called edaravone. So I'm sure the picture here is Stephen Hawking. I think everyone knows he was an astrophysicist. He suffered from motor neuron disease and passed away recently at the age of about 70 plus. So in recent years, there's a lot of genetic discovery on motor neuron disease. In the early 90s, SOD1 mutation was discovered. And later on, C9orf, as you can see in the around 2000 to 2015, and there are so many genes that are actually linked to ALS. So what happens in motor neuron disease? There's progressive degeneration of the bed cell of the motor cortex, and degeneration of the motor nuclei of the lower brainstem, and degeneration of the anterior horn cells of the spinal cord. As we know, our spinal cord is divided into the cervical segment, the thoracic segment, and also the lumbosacral segments. So all these give rise to the constellation of the upper motor neuron and the lower motor neuron signs in ALS. The upper motor neuron signs are hypertonia, hyperreflexia, Hoffman signs, clonus, and Babinski signs. The lower motor neuron signs are like hypotonia, hypo or areflexia, wasting, and fasciculation. So let's say the lower motor neuron sign affect the cranial bulbar segment, you will get bulbar palsy. For example, you have tongue wasting and fasciculation, you have reduced intellectual elevation, you have absent gag reflex. And if upper motor neuron signs affect the cranial bulbar region, you get pseudobulbar palsy. So someone can present with uncontrollable crying or laughing or forceful yawning, and increase in jaw jerk or brisk gag reflex. So motor neuron disease has a progressive course. There is no effective treatment, and the median survival is usually about 3 to 5 years. Most patients will die of respiratory failure. The pathogenesis was proposed to be actually, there are multiple mechanisms that can lead to motor neuron disease. For example, genetic susceptibility, disturbed RNA metabolism, impaired DNA repair, and excitotoxicity and mitochondrial dysfunction. It's important for us to recognize the cardinal features of ALS. First, the hallmark of it is combination of upper and lower motor neuron signs. The pattern usually will follow my specific myotomes, and the disease is actually progressive and there is spread. For example, spreading from the distal to proximal and spreading to contralateral contiguous segments. There is no sensory loss, and particularly there is extraocular muscles and sphincter. Typically, they are not involved. Diagnosis mainly is clinical. EMG, however, can support the diagnosis by showing evidence of active denervation. For example, the EMG here shows fibrillation and positive shock waves. These are hallmark of active denervation, and very important to exclude mimics, other conditions that can mimic ALS. So the typical ALS is a combination of upper and lower motor neuron signs affecting multiple spinal segments. By segment, I mean either it's cranial bulbar, cervical, thoracic, or lumbosacral segments. And most commonly, this is adult in onset, and the median survival is about 3 to 5 years. Of course, there are other variants of ALS that we should be aware of. Primary lateral sclerosis, or PLS, is a pure upper motor neuron syndrome. This patient has a much better prognosis. Usually, they can live even up to 20 years. Progressive muscular atrophy is a pure lower motor neuron syndrome, and they have variable evolution to ALS. The median survival typically is about 5 years, but there are a subset of survival who can be up to about 20 years. And progressive bulbar palsy is how it affects only the bulbar segment, where speech and swallowing initially affected owing to low motor neuron involvement of the cranial nerve 9, 10, 11, and 12. Symptoms include dysarthria, dysphagia, and dysphonia. And aspiration pneumonia is usually the cause of death and has a median survival of more or less about the same as ALS, about 2 to 3 years. So this is a graphic representation of the variant of MND. So the typical spinal onset of MND, combination of upper and lower motor neuron sign across multiple segments, bulbar onset that we mentioned, and progressive muscular atrophy, the pure lower motor neuron syndrome, the primary lateral sclerosis, the pure upper motor neuron syndrome. Other rarer syndrome, for example, pseudopolyneuritic ALS, hemiplegic ALS, flail arm syndrome or brachial diplegic syndrome, or the flail leg syndrome. Pure lower motor neuron syndrome, which is asymmetrical, affecting one limb. Other manifestation, for example, this wasted hand of the split hand sign is actually classically described in ALS, where there is wasting of the thenar eminence with a relative sparing of the hypothenar eminence. For example, you see that this picture right here, the abductor pollicis brevis or the APB and also the FDI, first dorsal interossei, they are markedly wasted as compared to the ADM or the adductor digiti minimi or the hypothenar region. So this is a classical sign of ALS. Some patients can present with drop head syndrome where there is weakness of the neck extensor, and flail arm variant or what we call brachial diplegic variant when there is a symmetrical low motor neuron syndrome of usually affecting the upper limb. Some patient can present with unexplained weight loss, and minority of the patient can present with respiratory failure in the onset. And there's significant overlap between ALS and frontotemporal dementia. So the diagnostic criteria, there are a few diagnostic criteria, for example, the L-Ascario criteria and revised L-Ascario criteria, and subsequently Awaji-Shima criteria came out in 2008. So the summary of it is, okay, so you have definite ALS, you have probable ALS, you have possible ALS. And the summary of it is you need combination of upper and lower motor neuron signs. If there is 3 segments that's involved, by segment I mean either it's craniobulbar, cervical, thoracolumbar, and thoracic or lumbosacral. So if you have a combination of upper and lower motor neuron sign in 3 or more segments, it is definite ALS. If you have 2 segments, it will be probable ALS, provided the upper motor neuron sign is rostral. So let's say the upper motor neuron sign is actually caudal, then it will become a possible ALS. If you have upper and lower motor neuron sign in only 1 segment, then it is possible ALS. And so that's L-Ascario criteria, the original L-Ascario criteria. Later, there is a revised L-Ascario criteria, which they added this clinically probable lab-supported ALS, which is you can use the EMG finding of active denervation to replace the lower motor neuron sign. And active denervation means fibrillation and positive shock waves. And later there is Awaji criteria. So Awaji criteria is about the same as revised L-Ascario criteria, but other than active denervation, it also recognizes fasciculation, EMG fasciculation, or chronic neurogenic units as a replacement for lower motor neuron signs. The Gold Cross criteria was proposed in 2019. Actually, this criteria allows for earlier detection of ALS. So it only actually requires progressive motor impairment from normal baseline, either from history or repeated assessment, and upper and lower motor neuron sign in only 1 body region, or lower motor neuron sign in 2 or more body region. And of course, the caveat will be investigation to exclude other differential diagnosis, either by way of MRI cervical spine, NCS EMG, or CSF analysis. So this criteria actually allows earlier detection of ALS because of the need for earlier, because there are research for intervention and medication for ALS. They need to detect ALS early for intervention. However, disease-modifying treatment is largely disappointing. Riluzole improves survival time to tracheostomy for about 3 months. It acts by inhibiting the NMDA receptor and inhibit glutamate release and reduce excitotoxicity. Side effects are transaminitis and somnolence. So management is largely supportive. If there is swallowing difficulty, dysphagia, PEG tube can be inserted. Someone with communication problem and dysarthria, speech and language therapy, eye tracking device can help. Pseudobulbar effect, dextromethorphan or SSRI can ameliorate the symptoms. Spasticity, quinine, baclofen or tizanidine can relieve the symptoms. Depression, psychological support and antidepressant. And for patients with respiratory failure, there's a role of non-invasive ventilation. So by and large, when someone is diagnosed with motor neuron disease, actually it spells bad news to the patient because treatment is so limited, definitive treatment is so limited, treatment is largely symptomatic, and prognosis is otherwise poor, which is why it is so important for us to recognize when someone presents to you, to recognize this is not MND. I will use a few cases to illustrate some conditions that can mimic MND, which is very important for us to recognize. So this is a 22 years old man, second-year medical student, came in with twitching of the calf muscles, and he is particularly concerned and asked, do I have ALS? On examination, you noted normal muscle bowel, tone, power, reflexes, all normal. And I'll just play this video. So you can see that there is some sudden random twitching of the calf muscles that you can see. So random twitching of the calf muscles. So this patient does not have MND. This patient has benign fasciculation syndrome. So fasciculation does not equal motor neuron disease. So sometimes it can happen, especially there is no other signs to suggest upper and lower motor neuron signs. There's no wasting. There's no progression. There's no spread to other segment. It is not MND. So we should reassure the patient, especially we can monitor the patient, and then we should reassure them that this is benign fasciculation syndrome and not MND. Case number 2, 50 years old man presented with right-sided shoulder pain and occasionally radiate to the thumb and occasional neck pain. So the right side, there is weakness of shoulder abduction, elbow flexion, power of 4+, absence of bicep jerk, supinated jerk. So you can see that there's weakness following the C5, C6, the myotome, and absent bicep jerk and supinated jerk. This is C5, C6. And Hoffman sign is positive bilaterally. This picture shows a positive Hoffman sign when you flick the middle phalanx and there's involuntary flexion of the thumb. And Hoffman is positive bilaterally. So, so both lower limbs tone are increased, wrist, knee, and ankle jerks. There's non-sustained clonus and plantars are outgoing. So you have upper motor neuron sign in the lower limb, and you have the lower motor neuron sign in the upper limb and upper motor neuron sign in the lower limb. So is this MND? No, actually this patient has got cervical spondylotic myeloradiculopathy. So degenerative changes, degenerative disease affecting the spine is actually particularly common, and it's something important for us to exclude. So the MRI of this patient shows degenerative spine disease where there is compression of the spinal cord. So you can see there is a cord compression with edema, and that gives rise to lower motor neuron sign in the lower limb or myelopathy. And also at the C5, C6 segment, there is this protrusion causing foramina stenosis and impingement of the C5, C6 root that gives rise to C5, C6 radiculopathy. So you have a combination of lower motor neuron sign and you have upper motor neuron sign in the lower limb, all due to degenerative changes. So this is something important for us to exclude. However, on the other hand, there are cases of it's very important for us not to attribute signs to radiculopathy if there's no radiological correlation, especially in the absence of sensory symptoms. So someone can present who genuinely have a upper motor neuron disease, but you do an MRI spine and there are changes, degenerative changes, which is actually very common. And we should not just attribute that to degenerative disease just because we see some abnormalities in the MRI spine. If anything, everything else correlate with motor neuron disease, and this is motor neuron disease, because we have seen cases of actually motor neuron disease, and they went on to do orthopedic surgeon went on to do a compressive decompression, and there's no improvement. So in both ways, we have to be careful of this mimic. And because NCS and EMG changes can closely resemble MND, and then the giveaway point will be sensory symptom and neck pain, because MND usually they do not have any sensory abnormalities, where myeloradiculopathy or cervical spondylotic myeloradiculopathy, they can have sensory symptoms and they can have neck pain. Case number 3 is a 68-year-old man referred for progressive weakness of left lower limb for the past 2 years. On examination, you noted that there is left lower limb atrophy and weakness. There is absence of deep tendon reflex, and the sensory examination is normal. The strength and reflexes of the right lower limb and both upper limb, they are all normal. So this is a case of post-polio syndrome. Post-polio syndrome is a sequelae of previous poliomyelitis infection. It is already now rare since the mass vaccination. Poliovirus is enterovirus that affect the anterior horn cells, causing paralytic polio. Most people recover with some residual weakness, and later in life, they can present with worsening weakness. This is likely due to age-related loss of motor neuron. Case number 4, 50-year-old man with underlying diabetes, predominantly proximal weakness for the past 5 years, dysphagia, and you notice this perioral fasciculation. So this picture shows there's a tongue wasting and atrophy. So you also notice that there is perioral fasciculation, and this patient also has gynecomastia. So these are the differentiating features that you need to be aware of, because this is not motor neuron disease itself. This is Kennedy's disease. Kennedy's disease is also known as X-linked bulbar spinal muscular atrophy. This is a X-linked condition, a trinucleotide repeat disorder caused by androgen receptor mutation. Typically, someone will present in their 4th or 5th decades with proximal weakness, tongue atrophy, mentalis or perioral fasciculation, and there is hypogonadism and gynecomastia. Patients with Kennedy's disease, they have a better prognosis compared to ALS, because they essentially can live a normal life expectancy, of course with significant morbidity, but they have normal survival compared to ALS. Case number 5 is a 23-year-old man, came in with progressive right upper limb weakness, no sensory disturbance. So as you can see, the left upper limb is actually wasted. There's muscle wasting involving the small hand muscles. And the forearm, there's also wasting, and especially the long finger flexors. So as you can see here, if you notice, there's this oblique atrophy, what we call oblique amyotrophy, with a relative sparing of the brachioradialis, which is actually innervated by the C5, C6 myotome. So the other finger flexors muscles in the forearm are spared. This is a case of Hirayama disease, also known as cervical flexion myelopathy or monomelic amyotrophy. This is due to an imbalanced growth between vertebral column and spinal contents. The tight dural sac causing when there is neck flexion, it will displace the anterior dural wall, and it will compress the anterior spinal artery, leading to microvascular ischemia of the anterior horn cells. And the deficit usually is asymmetrical, involving the C7 and below. And usually the natural cause of the disease is there are a few years of progression followed by stabilization. It usually affects the Japanese population and the Indian population, and usually affect teenagers. There will be a few years of progression followed by stabilization. So it does not spread to other regions like motor neuron disease. It may affect the contralateral limb, but they do not progress to involve other segments. Case number 6, 40 years old man present with swallowing difficulty, bulbar speech, mild tongue atrophy, mild bilateral ptosis, and bifacial weakness. So what is the smoking gun here? Actually, you can see that there is ptosis, facial weakness, which is not commonly affected in motor neuron disease. And you would think that this patient maybe has myasthenia gravis. So the doctor did send the acetylcholine receptor antibody, which turned out to be negative. And a trial of pyridostigmine did not show any improvement. And lo and behold, anti-mass antibody is positive. And this patient has got anti-mass myasthenia gravis. So myasthenia gravis is a neuromuscular junction transmission disorder caused by antibodies against acetylcholine receptor in the motor end plate. The characteristic features are fluctuation of symptoms and fatigability. And it is not, it's fluctuating, it's not progressive. And there's ocular MG, it's generalized MG. Among the generalized MG, 85% are acetylcholine receptor antibody positive, 15% of them are seronegative, and half of which they are positive. So by and large, most myasthenia gravis, when someone with myasthenia gravis, they are rarely, if ever, confused with ALS, unless the rarer anti-mass MG, because sometimes they can have oculobulbar facial weakness and minimal limb weakness. And some patients may have tongue wasting or atrophy. They are at risk of myasthenia gravis MG crisis. And actually, pyridostigmine may paradoxically worsen their symptoms. They usually respond to plasma exchange and rituximab. Case number 7, 20 years old male with a normal developmental history, presented with progressive weakness since the age of 14. And you notice that there is a proximal symmetrical weakness, especially the shoulder abduction, elbow, shoulder abduction is weak. Hip flexor is actually weaker than hip extensor. Knee flexor is weaker than the extensor. There is a generalized hyporeflexia, and patient is now currently wheelchair bound. And the CK is only mildly elevated, about 400. So you would think that this is like a proximal, symmetrical proximal weakness. The most likely cause is like a proximal myopathy, or even like something like a neuromuscular junction transmission disorder. But if you do the EMG, you find something very surprising. Actually, instead of myopathic changes, you see neurogenic changes in the affected muscles. So these are neurogenic units, which are large units. Okay, so it points towards something else, that this is a neurogenic process. And the genetic test is positive for homozygous deletion of SMN1 gene. And this patient has got spinal muscular atrophy. Spinal muscular atrophy is an autosomal recessive disorder caused by SMN1 gene mutation. It is a progressive loss. It is caused by a progressive loss of anterior horn cells. So in human, we have a SMN1 protein. 90% of us is by SMN1, and another 10% is SMN2 gene. So SMA actually has a heterogeneous presentation. You have SMN1, 2, 3, and 4. The severity depends on the copy number of SMN2. It ranges from 2 copies up to 5 copies. So SMN1 and 2, they are infantile in onset. SMA3 is usually someone present in their childhood. SMA4 is someone in their adulthood. So it presents with a lower motor neuron syndrome. So depending on the copy numbers, if someone has high copy numbers, they can present in adult onset presentation, and they have a milder disease. Case number 8, 7 years old boy, normal development and walking until 4 years old. Subsequently, he had a progressive bilateral lower limb weakness. So you notice that on examination, there is hip flexion is weaker than extension. Knee flexion is weaker than extension, and ankle dorsiflexion is weaker than plantar flexion. It follows a pyramidal kind of distribution, and there's bilateral lower limb hypertonia and hyperreflexia. So it points towards like a pyramidal weakness. You think that this is like a myelopathy, and however, MRI spine is normal. So this is a case of hereditary spastic paraplegia. It is a heterogeneous group of disorders. At least more than 70 different genes has been identified. They can be autosomal dominant, autosomal recessive, or X-linked. It's caused by progressive degeneration of the corticospinal tract, mostly confined to lower limbs. So most of them have pure upper motor neuron syndromes. However, that being said, there is, because of the heterogeneity of the disease, you can have HSP+, where you have overlapping syndrome with peripheral neuropathy. Some patients can have intellectual disability and ataxia. Case number 9, this is a 40 years old man, progressive left upper limb weakness. And on examination, you notice that there is weak wrist, finger extension, and thumb flexion and abduction, and reduced tricep jerk, and normal sensation. So this is an asymmetrical upper limb, distal weakness with no sensory loss. And during NCS, you notice this demyelinating features on NCS. So this is like what we call conduction block and temporal dispersion. This is a sign of acquired cause of demyelination. So anti-GM1 is positive in this patient. So this is a case of multifocal motor neuropathy with conduction block. So it follows, you would suspect this is something that can closely mimic motor neuron disease, when they can only affect the motor, distal, but the distribution, it follows a particular nerve rather than myotome in motor neuron disease. And the NCS shows demyelination, whereas in motor neuron disease, the NCS will show something like an axonopathy. Okay, and this condition is favorable. It responds to IVIG. Case number 10. This is a 65 years old man, present with progressive upper and lower limb weakness for the past 5 years. So you notice that there is a wasting of the quadricep muscle with relative sparing of the rectus femoris. You notice that there is distal upper limb weakness, especially the long finger flexors. Usually in most conditions, the finger flexors is actually quite strong compared to the finger extensor. But when you see there is weakness of finger flexor, you have to think about this condition. Okay, so the finger flexor is actually weak, and there is some asymmetry. Knee extensor there is some asymmetry as well. There is particular weakness, severe weakness over the knee extensor and ankle dorsiflexion. So the quadricep, that can explain the quadricep weakness and wasting. Reflexes is normal, and there's no sensory loss. And the CK is of 2000. So this is a case of inclusion body myositis. It affects the older age group of patients. There is some male preponderance. insidious onset and slow progression. The weakness usually affect the long finger flexors and quadriceps, and they can be associated with dysphagia. The CK usually is usually normal to 10 times the upper limit of normal, and EMG may show mixed neurogenic and myopathic units. And muscle biopsy show intrasite cytoplasmic inclusion and rim vacuoles. Anti-CN1A is positive in inclusion body myositis. This is an antibody identified in recent years. So in someone with IBM, inclusion body myositis, the disease is actually progressive, but it's rather insidious in onset, and usually it affects the older age group, and they have a much better prognosis compared to ALS. It's actually a muscle condition, and they have a better prognosis, and they don't go into a respiratory failure. Okay, they may have some dysphagia, which can be prone to aspiration pneumonia. Case 11 is a 52-year-old man present with a chronic smoker, noted to have left hand weakness and wasting, and numbness of the 4th and 5th digits. So we have to be careful when someone with left hand weakness, but when there is numbness and sensory symptoms, we need to think of something else. So this patient, if you notice that he has left-sided ptosis, this is Horner syndrome on the left side. There is a radiation mark on the left supraclavicular fossa and upper chest area. And you do the chest X-ray, there is a apical lung mass. So this patient has thoracic outlet obstruction caused by apical lung mass or tumor. So thoracic outlet obstruction is caused by, so this is a thoracic outlet. So something that can causes thoracic outlet obstruction can compress on the lower trunk of the brachial plexus, causing a C8-T1 deficit. That is why you have a wasting of the small muscles of the hands. And because of the disruption of the sympathetic trunk, they can have Horner syndrome. Case number 12, 48-year-old lady with progressive bilateral hand weakness and numbness, upper limb distal weakness, and small muscles, weakness of the small muscles, and absent bicep jerk, tricep jerk, and supinated jerk. So you can see there's a lower motor neuron sign involving the upper limb. There's lower limb hyperreflexia, clonus bilaterally. So upper motor neuron sign of the lower limb. And reduced pinprick sensation was on the upper limb, right side to the elbow. Left side is the whole upper limb, and intact proprioception. So you see there is some asymmetry in the distribution. The sensory loss, you can see this dissociative sensory loss, where there is a loss of pinprick sensation and intact proprioception, which preserve the dorsal column. And you notice these burn marks, so they can have painless burns because of loss of pain sensation. So they can also have Horner syndrome. Okay, there's ptosis and isochoria, where there is meiosis and enophthalmos of this eye. So this patient has got syringomyelia. Syringomyelia is a fluid-filled cavity in the spinal cord. Usually in the middle of the spinal cord. They can expand anterolaterally, giving rise to all the signs that we have. So this patient has got a Arnold-Cherry malformation type 1, when there is a herniation of the cerebellar tonsil downward from the foramen magnum. So this can disrupt the CSF flow, causing a syringomyelia. Other causes of syringomyelia are like trauma, transverse myelitis, and arachnoiditis. So the take-home message will be motor neuron disease is follow a progressive course. There's no effective treatment. ALS or amyotrophic lateral sclerosis is the prototype of motor neuron disease, but there are a few variants that we should be aware of. On the other hand, there are other conditions that can mimic motor neuron disease. It is very important for us to pay attention to atypical features suggesting alternative diagnosis. And it is very important for us to always exclude treatable causes. When in doubt, we should revisit and revise diagnosis. I will end with a quote by Lou Gehrig himself. This is after his diagnosis, a famous speech of his. I might have been given a bad break, but I've got an awful lot to live for.